So good evening, everyone. I'm really happy to be here. After the lecture of Professor Joe, I'm speechless. So, I was speechless after the lecture. I'm really proud to be there in Shanghai and to have Professor Joe as my mentor. It's really amazing. He's doing magic every day. So back to reality. We're speaking about optimizing image enhancement towards a better outcome. The thing about image enhancement لما نيجي نفكر فيها كده it's a bit complicated لما تيجي تخش في التفاصيل و sophistications of the image enhancement and the optimization of the فأنا سألت نفسي سؤال what do I need as an endoscopist؟ أنا كدكتور مناظير أنا محتاج إيه؟ Of course, all of us want a better outcome for the patient. We need a better outcome. It starts with what we see, to have a better diagnosis. So you will have a better decision making. And your decision, we search for safety and efficacy. So what you need to reach your outcome, to have a safe and effective outcome, you need to see better, to have a better data interpretation, to take the right decision. So it's all about what you see. It's the optical diagnosis, and we have a lot of papers all over the world years ago in comparison to other modalities, imaging, endosonography, whatever the other modalities, they compare the optical diagnosis. The optical diagnosis stays number one for the diagnosing the lesion. Here is one of the meta-analyses about the sensitivity and specificity of the optical diagnosis and how it's really high and it's helping a lot in diagnosing the lesions. So we have a lot of scoring systems, Paris, JNet, NICE, Kudu, and other classification. Why do we have all these kind of classifications? Why? Because we need to have data, full data, because we need to know more about our lesions so we can take the right decision. So we learned in China, we learned in Shanghai that you have to have full details about your lesion. You have to have a map for your lesion. You map your lesion so that you put a proper plan. It's not only about the site and the size. No, you need to know the details, the surface pattern, the vascular pattern. It's about what do you think this lesion is. Is it benign? Is it malignant? Is it invasive? Even if it's malignant. So we need to have a lot of data. So they are speaking about high definition image and ultra high definition, now the 4K processing algorithms, a lot of sophisticated stuff, AI طبعا على رأسهم. So we have a lot of enhancing images. ايه رأيكم في الصور دي؟ دكتور مازن ايه رأي حضرتك في الصور دي؟ These are images from our real patients. What do you think? A good quality images? Sherbini.
Moderate quality. Moderate quality.
Moderate quality or a good quality? This is high definition scope. No one can deny that this is a good quality. So by terms of high definition, this is high definition scope. But what do you think about this image?
It's very good quality.
Yes, exactly. So this is the coming image. This is the new data that we want to have we want to know more about the details. Although that on the left side, the image is on the left side, it's a high definition scope and you can see also the details. But now, if you see the image of Olympus X1 and with the narrow band, even the narrow band itself is totally different. You can see even the details. So what do you think about this image? Dr. Sharif, ايه رأي حضرتك? We can have more data, right? So let us be more greedy. We want more. So this is these images are from our patients. These patients that we have resected the lesions for. And these are true images. These are real life images from our patients. You can see the image is amazing. But we need more. Do we need more? Yes. What about this image? What do you think? Dr. Ayman, رأي حضرتك? Yes. So here, when we combine modalities together, this is the near focus. As you can see here, the near focus. ممكن pointer يا جماعة? Here is the near focus combined with the MBI. As you can see here, you can see even the details. You can see the shape of the blood vessels. You can see the dysplastic areas are areas of dysplasia. So we can go in more in depth towards the lesion. This is a female patient who have a positive occult blood stools, and we are now in the transverse colon withdrawing the scope and using the white light. And there is something, looks that there is an irregular something on the right side on 3 o'clock. And then we have to come closer. We have to come closer. It looks like we are having something here. Oh, it's an adenoma maybe. So we turn to the narrow band now, and we come closer, completely underwater immersion, and here it appears, wow, it's a lateral spreading tumor. Maybe it's taking like 40% of the circumference. And then you look downwards, as you see at 6 o'clock, it looks like a monster here. What do you think about this image? Can you expect the pathology? ماذا الشربيني يعرف الحالة. دكتور مازن رأي حضرتك. What do you think?
It looks
like
adenoma with also some deep invasion.
Yes. Do you think it's an early cancer?
Again?
Do you think it's an early cancer? Early
Yes.
cancer?
Yes, early cancer, sure.
So do you think the narrow band had make a difference in this patient? Actually, with the white light, we could see just some irregularities on the right side, and with the MBI, underwater immersion, with the near focus, you can see even the details. And we resected this lesion, and it was a serrated adenoma with dysplasia. So it was not a cancer, although it looks like a monster, but actually at the end of the day, it was a serrated adenoma. And here is the TXI mode, which we call the new white light. Sherbini, what do you prefer, TXI or MBI?
Actually, we prefer the NBI to know more details, to know the pathology surface pattern and vascular pattern, even the dysplasia, if it's combined with near focus. But regarding TXI, I prefer sometimes to work in diagnosis or in diagnostic endoscopy was using new white light TXI more than the regular white light.
Yes, I totally agree with you. I think that MBI is still on the top. Maybe TXI could be the new white light. So here is another lesion. Here is a lesion that was diagnosed. It's the opposite side. It was diagnosed as a cancer, and it's not a cancer. As you can see here, it's an LST with the previous true trials of resection. It's an anorectal lesion. And now we are doing the steps. We, after characterizing the lesion, we start from the cecal side of the lesion. As you can see here, there's the blue submucosa, which is really, it's not only about detecting the lesion and characterizing the lesion. It's really important that you clearly see every detail during the resection. Here, we shift to the anal side, and then we start creating another pocket on the anal side, and then we communicate two pockets together, what we call it the bridge technique. You can see here, here's the submucosa, and we use the cap, of course, it helps a lot. And then we create our pocket. You can see here the demarcation is really clear between the submucosa and the muscle, and you can see even the minute or small blood vessels. So here's our bridge is formed. This is not a perforation, it's a bridge. And then we go through the bridge and we do a retroflexion gently. And you can see here, this is like doing a maximum traction to the lesion. And then we remove the lesion. And here we inspect the bed. So the vision is extremely important, not only for detection, not only for characterization, but also during the resection. As you can see here, it's quite evident. It's not cancer. It's just a high-grade dysplasia. So I have a very interesting patient here. She's a 50-year-old patient, and she had a lateral spreading tumor in the rectum, for which she had trial of resection with EMR and argon plasma coagulation, which is really extremely strange. And then here is our assessment. As you can see here, here is the anal canal, and here's the rectum. There is a scar, fibrosis. We're not sure this is a scar or fibrosis or just, or maybe it's an invasion. Here's, we use the MBI. As you can see here. So the demarcation becomes more and more evident, and we will do a retroflexion to expose the lesion completely. And there is a central area of depression. Dr. Mason, shall we proceed? ما تقوليش EMR والنبي عشان ما ازعلش.
برضه ممكن.
دكتور علي. دكتور علي رأي حضرتك ايه؟
very suspicious وانا لازم EUS انا قاعد جنبك على طول.
ماشي.
ليه؟ لان مش بس هتشوفي T3 و T4 هتشوفي nearby lymph nodes.
تمام.
ده very suspicious lesion طبعا.
So do you think this is a suspicious lesion with a central depression? دكتور شريف، دكتور أيمن، رأي حضرتك كده برضو؟ اوكي.
اعتقد ان المكان ده هيبقى سيف في الاي اس دي، لكن السنترال ديبريشن ده بيوحي ان ممكن يبقى it's an invasive tumor.
So what do you think what I shall do? Shall I send him for EUS, take biopsies? What do you think? The next step?
it is better not take biopsies.
Yes.
It's better not لانه هي induce more fibrosis وهيخليها more difficult يعني. being in a safe area rather safe area الواحد مش قلقان قوي من ال perforation فمتهيألي it's worse ان احنا نتشال.
طيب. So what about using the new enhancement in the image? To get close, here's the white light and here's the TXI, and we put a cap on the scope and we use the MBI underwater immersion with a near focus, and we started to inspect each part of the depressed area. You can see here, this is the near focus. Here, there is the near focus. You can see here. You come very close to your lesion. You know your lesion better. It's an amazing picture. As you can see here. So we put a cap for better exposure and we inspect the lesion, each part of the lesion. Here's the depressed area. We use also the TXI. It's clearly evident. And here comes the depressed area. We inspect each part of the depressed area and we see the blood vessel. And we started to inspect the depressed area all through. ايه رأي حضرتك يا دكتور أيمن بعد كده؟ Do you think it's an invasion or just a scar?
لغاية دلوقتي مش شايف أي حاجة تقول إنها it's an invasive tumor.
Yes.
It's a scarring بس.
Yes.
حتى شكل الفيسلز الفاسكولار باترن بتاعها ما يوحيش بأنها it's an invasive malignancy.
Yes, exactly. It's not an invasive cancer. It was just scarred from the previous trials. And then we resected the lesion, we removed it with ESD, and it's really important that you inspect the lesion even after the resection using the different modes like the TXI and the MBI. So also one of the amazing properties in the Olympus X1 is the RDI mode. And this is essentially for bleeding. This is part from Professor Joe's procedure yesterday where we had some bleeding. And we can use the RDI. RDI stands for red dichromatic imaging. It's specific for the deep vessels. As you can see here, we can clearly identify the bleeding point because it's important for us not to do just like blind coagulation. It can cause injury. It can cause perforation. So localizing the source of bleeding is really important. So with a very gentle coagulation, we could control the bleeding. And this is the lesion of yesterday. It was 12 centimeter. And of course, Professor Joe. But we think the scope was really very nice and it helps a lot using the technology. What do you think, Professor Joe? Do you think the new technology helped you yesterday?
Yes, yes. I really enjoy the new product from Olympus.
Yes, okay, thank you. I say that's a mucosal tumor. So, so if we were speaking about AI, we can, we did not, we still don't have the AI in our unit yet. We have X1, but we don't have the AI yet. But of course, we know that AI is helping a lot. As you can see here, it doesn't look that you can see something, but it just pick it up, and then you come closer, closer, and then afterwards, it's an adenoma. So this is the AI, although the studies are yet not conclusive. Here's what's so important here is that we can have multiple images, from the target mode while it's on, we have multiple images for the polyps, for multiple polyps in the same image, just to detect if you have multiple polyps. And also one of the new things that we have in Olympus that sometimes some endoscopists find it's annoying to have this box in the view, so they put the new mode where they just highlight here that you have something. Here is in the cecum, and here's the AI. There will be highlighted here, the AUS mode. It's highlighted here that you have something, and also at the same time, so I give it a thing. And the same time, it just gets on the right side here. We can find that the demarcation here, so not to annoy the endoscopist if you don't want the box inside your view. I will end my presentation. This is the expert opinion of one of the meta-analysis about the use of the new enhancement or the new images. How could it help? It helps from the very beginning, from the detection and characterization, and even during the therapeutic resection. So this is my team. Thank you.